There is actually a misperception. It's very easy to lose weight, but maintaining weight actually is hard.
Yeah.
With almost 1 billion people suffering from obesity or overweight worldwide.
Welcome to Leading Beyond the Lab. Today I'm really excited to be joined by Jyothis George, a biotech leader helping to shape the future of the cardio-metabolic and inflammatory disease space. Where do you think that industry or that part of the market will go to?
So I see the industry falling into 3 camps. One is the incumbents, Novo I worked for, Lilly I worked with. Then you got 2 is the fragmenters. You mentioned my time at Amgen. We actually developed a long-acting, less frequent antibody peptide conjugate that will actually serve a good proportion of the market. And 3 are the leapfroggers. These are people who are actually trying to develop new mechanisms that are complementary to GLP but would radically transform the way in which obesity is treated.
So what drew you to join NodThera?
This company, I truly believe NLRP3s could actually serve millions of patients. How lucky is it that actually you can tell that you have actually touched the life of millions of people out there? Somebody is popping a tablet in the morning, hoping to have a better day and a better life because you invested some of your hard work.
So final question, Jyothis. What do you think will be the big developments to keep an eye out for over the next 5 to 10 years?
Well, obesity is the foundation of more than 200 diseases that we all worry about. So the next stage of innovation would need to come from
Hello and welcome to Leading Beyond the Lab. Today I'm really excited to be joined by Jyothis George, a biotech leader helping to shape the future of the cardio-metabolic and inflammatory disease space. From leading global programs with the likes of Novo Nordisk, Amgen and Boehringer Ingelheim, to now joining the world of biotech with NodThera, Jyothis has been at the epicenter of some of the most important shifts in the chronic cardio-metabolic disease area. Now Jyothis is leading NodThera's efforts in unlocking the potential behind the NLRP3's inhibition in chronic disease. Today we talk all things GLP-1, inflammation, cardio-metabolic disease spaces, and I'd like to get an expert insight into what the next scientific breakthroughs are going to be in this area. So let's get into it. So Jyothis, you are an endocrinologist by training. You have researched at some of the most esteemed academic institutions in the land in this area. I'd love to hear in your words, what drew you to join NodThera?
Before I answer your question, Lawrence, what you do, I think, is truly important. I personally believe there is a huge journey from going from an expert in the field to a leader in the field. And what you do for this fantastic audience is tremendous. So keep doing what you're doing.
Thank you, Jyothis.
So thank you for having me here. So what attracted me to NodThera is the same thing that attracted me to the great companies that you mentioned. I've had the privilege to work on 3 wonderful cardiometabolic classes, SGLT2s, GLP-1s, and PCSK9. And I truly believe NLRP3s could become that next mega class in the cardiometabolic place that could actually serve millions of patients. That's what attracted me.
And what do you think about its approach makes it so distinctive and unique?
What is most fascinating is this company, I'm privileged to say actually, is built on a decade of hard work by my fantastic scientific colleagues. They've actually made sure we have NLRP3 inhibitors that reach the right tissue at the right dose at the right time. What does that mean? That means we've got brain-penetrant NLRP3 inhibitors that other people do not have. We are able to lower systemic exposure where we need to. And most importantly, we've actually evolved the molecular structure to actually have a confidence in the benefit-risk profile that we offer. So it's a great time for someone like me who's a clinical developer to build on those molecules and take it towards proper medicines for people.
And given the interest right now and investment that's going into GLP-1s and generally the obesity space, I'd love to hear your thoughts on what makes NodThera more unique or complementary, if you like, to these other modalities and indications.
Yeah, for a great cardiometabolic drug, I think you need 3 things. One is metabolic benefit. You've got to show improvements in obesity or diabetes, that sort of thing. The second one is showing improvements in cardiovascular disease risk. And the third thing actually is improving what we call obesity-related conditions. So in all these things, you've seen GLP-1s delivering for patients. And that's why, like you said, there's a lot of investment going into that place. Yet we know this is a disease that affects 1 billion people worldwide. And in most chronic diseases, you actually need more than one modality that complements each other. So GLP-1s are great, but yet people struggle taking them. There are unmet need remaining even after GLP-1s are so successful, that's where approaches like what we do at NodThera come into play.
So what upcoming clinical milestones have NodThera got to look forward to?
So Lawrence, we spoke about great cardiometabolic drugs needing three things, right? One, metabolic improvement, two, cardiovascular benefits, and three, benefits in things like complications in the brain or any other obesity-related comorbidity. So what we've already shown with NodThera's lead asset is cardiovascular risk reduction with biomarkers that's comparable to the best-in-class injectable. So think of it as small molecule benefit providing the same or similar benefit to injectable biologics. That's great. And we've also published neurodegeneration improvements with the same molecule. We now have 2 obesity trials ongoing, which report in the middle of next year, that completes the triad of benefit I was talking about, of metabolic benefit, cardiovascular benefit, and benefit in complications of these 2 things. So that sets us up for addressing a large number of people in a meaningful way. So very excited about those readouts coming.
And for physicians and listeners from the audience that aren't necessarily endocrinologists or involved in the obesity space, they've probably seen a lot of what's in the news right now around the products that are available. I'd love to hear in your words a simplified version of why obesity is such an important area right now.
Obesity is the foundation of more than 200 diseases that we all worry about, the biggest public health crisis. And I want to just maybe think about the American Heart Association calling obesity a stage 1 cardiovascular disease. So that's where the seeds are sown for future complications like heart attacks and stroke. So in obesity, what we've now seen is the recognition that it's a disease and that you can actually prevent future complications by addressing obesity early. What we also know is it's no longer about your willpower or my willpower about eating less or moving more. The biology is getting increasingly clear. There is actually within our brains what I would like to tell lay people like a thermostat for the amount of fat. The official term is defended fat mass, but I like more like the fat stat or the fat thermostat. That is set at a certain point for all of us. And what we know is that particular part of the brain called hypothalamus gets inflamed very quickly with a fatty diet or the environment we live in. So what we are trying to do is to address that inflammation, reset that thermostat, and hopefully that will help us from preventing gaining weight after you lose weight and to maintain weight. That'll be a fantastic solution for millions of people out there.
And where do you think that industry or that part of the market will go to? Because naturally, you can only lose so much weight and you can only get your medicines to be so effective. So what do you think the life cycle of that is?
You're absolutely right. There is actually a misperception, perhaps in the field, that the biggest number that you can see in a clinical trial about weight loss is the biggest thing that is out there for a drug. Anybody who's tried to lose weight, your listeners or any of us know that it's very easy often to lose weight, but maintaining weight actually is hard. That needs a reset of the biology. So yes, there'll be new mechanisms that actually come in to help. But to your question, where is the market going? I see the industry falling into 3 camps. 1 is the incumbents, 2 is the fragmenters, and 3 are the leapfroggers. The incumbents are Novo, I worked for, and Lilly, I worked with, right? They are the incumbents, and you probably might want to think about Pfizer as a new entrant with Metsera acquisition in that incumbent place with large companies being in there. Then you got fragmenters. You mentioned my time at Amgen. We actually developed a long-acting, once a month or less frequent antibody peptide conjugate. And that will actually serve a good proportion of the market, hopefully, where that convenience of once a month and the other benefits you bring would be good. And the last category, I think, but the most exciting category is the leapfroggers. These are people who are actually trying to develop new mechanisms that are complementary to GLP, but would radically transform the way in which obesity is treated. And if you think about any innovation in any industry, you actually find the incumbents may not be always the ones to come with the innovation. And that's where smaller biotechs like ours come in to say, okay, we explore the chronic inflammation hypothesis in the hypothalamus and the peripheral tissue. Could that be a complement, right, to the existing incumbent approach?
Yeah, it's really interesting, isn't it? I don't know where the ceiling is in terms of the space.
The ceiling is almost not there. That's also the opportunity and the challenge. With almost 1 billion people suffering from obesity or overweight worldwide, the what you would call the total addressable market actually is very huge. But that also means you've got to be smart about how we tackle it. You've actually got to think about this in segments, in categories. I use the analogy of cancer. 20, 30 years ago, we thought of cancer as one disease. Then it became a cancer of an organ. Then it became a cancer of a tissue. Now we think about it a cancer of a particular cell type or a genotype. In a similar way, obesity is not one disease. The reason why people actually put on weight and struggle to lose weight, struggle to maintain, is a complex multifactorial disease. So it's a mathematical misconcept to think that a billion is the same. It cannot be, right? So segmentation, stratification, and much more precision type approaches will have to come into play, like in any other diseases, right?
Yeah. Looking at your background, Jyothis, you are a proven leader and thought leader in the space. You have led programs with the big companies that we've mentioned. What are the key lessons that you take forward with you into your role now?
I think the first and foremost lesson for anybody who's working in your industry is to put your patients first. I mean, Lawrence, I'm lucky to say my mother was on a medicine that I got at least one FDA approval for and led clinical trials for, right?
That must be amazing as a feeling.
It was amazing. And actually, that's the only medicine that she never skipped taking because it was she knew that I had carefully looked at the benefit risk myself. So the message for me and anybody else working in this field is, if you're developing something, be ruthless at looking at the benefit risk of your drugs. We are in a world where people actually want to hype up certain molecules or pathways, but no, be absolutely dogmatic and precise as looking at the benefit risk. But once you establish the benefit risk in your mind and in the regulator's mind, then be relentless in making sure you got access and adoption of your drug. Our industry still struggles in actually getting to people who need treatment. You said GLP-1s are a success, but a single-digit percentage of the people worldwide who needs it are getting it. So that's where scalable solutions like oral small molecules that can be produced at lower cost, distributed without cold chain, will actually become part of it. So what are the lessons that I see as transcribable from across big company to small? Putting your patients first and serving their needs. Like in any other industry, think of your customer first. I don't think you can be much wrong if you do that every day.
Yeah, one of the nice things about your industry is that people go into it, although they're competing as companies, they're still going into it with ultimately the same common goal, which is to help the patients and caregivers.
Yeah, and that, if you forget that even for a second, then I think you lose your purpose. But that's also the opportunity for leaders like me to actually remind people constantly what is the purpose, and reorienting towards that purpose is also that sort of leadership mantra. Sometimes your teams, yourself, get into the details of, oh my God, yet another slide deck to do for a presentation tomorrow. But you've got to find a way to step back and say, I'm actually doing something truly transformative for somebody's mother, somebody's father, brother, son, or probably yourself down the years. So
is that your purpose, or what would you say your purpose is?
I think very much so. As a drug developer, you have to be thinking about patients first. I spoke to a lady who's suffering from a rare cardiac disease just last Friday, and she was very much willing to be partnering with me in thinking about new ideas. But as a parting thing, she actually said, Jyothis, will you and your colleagues in the industry make sure we are not treated as guinea pig for yet another drug? And then when it comes to approval, we can't buy it and we can't use it, right? So I would like us to all remind that we have to think about the patient first. The second thing is, maybe I'm getting older, Lawrence. My 50th birthday is coming up in the not too distant future. But the second purpose really is to train and support the next generation. So the reason why I came all the way from Oxford to see you is actually to give back and pay forward. That hopefully somebody will actually find their own purpose, their own leadership skills, and actually unlocking their potential and the biotech's potential.
And with that in mind, what program are you most proud of in terms of your achievements to date?
I think that's like asking a parent who's their favorite child.
Yeah, that's such a good way
I have
to
a
put it.
son and a daughter. I tell them I have my favorite son and I have a favorite daughter. Similarly, I've got a favorite GLP-1, a favorite SGLT2, a favorite PCSK9, I have a favorite NLRP3, or maybe more than one favorite NLRP3. But when you look back, getting that very first approval of a cardiovascular death indication for any diabetes drug for empagliflozin, almost everything that my colleagues and external advisors told the FDA came through my laptop. At that point, I was like, oh my God, this is such a tight vote that we won. But on looking back, it just transformed the field of diabetes care. So hopefully there are more moments like that to come with NLRP3 or anything else. But yeah, often in the moment, you don't realize how catalytic it is for yourself or for the public health perspective. Yeah, but you think you find these rocking chair moments only when you look back in a decade or so.
And with all that pressure, with those such important goals in mind, how do you lead clinical and translational teams in this kind of high reward, high risk environment?
Yeah, I think the first thing is sheer focus. It's very easy to get distracted by a new idea a day. I literally call them ideas of the day that people actually have, and especially in R&D field, it's very easy for us to get distracted. When you have a powerful mechanism, I mentioned SGLT2, GLP-1, and now NLRP3, there are so many indications that actually you could take this down. So one of the things that we've done as a company is to focus down to what I call 4 paths to patients. 1 is cardiovascular, 2 is obesity, 3 is neurodegeneration, 4 pain and peripheral inflammation. So everything that we do, you focus on those 4 parts. We will reserve some part of our brain power for other things, new white space opportunities, but that cannot come at the cost of your main goal. So one thing actually is finding focus. We also already mentioned the value of purpose to actually keep going. The third thing I would actually say is drug discovery is the ultimate team sport. Right? Yet the people who come into the industry are usually selected for self-success as an individual. So part of the art in being successful in this industry or transitioning here or being successful is putting your ego to one side. Yes, you're here only because you're a smart person, but everybody else is a smart person too.
Yeah.
And then to have what I call the spirit to debate vigorously. But once the debate is done, you decide.
What spirited debate? Tell me more about what that means.
Yeah, because I think, in the R&D field, people actually have very different ideas, what a new indication could be, how a trial could be. And what I do as a leader and as a member of team actually is to find space and time for people to have different perspectives. Okay, Lawrence, what do you think the approach should be? Lawrence B, what do you think the approach should be? We make a table, pros, cons, and whatever. Then you make a decision. And that decision point is also important because we have to say now we all commit to that decision. Lawrence, you may not agree with the collection's view, but you've got to commit to that decision. You got to deliver. So that's what I call 3 Ds: debate, decide, and deliver. Then you find a time in your calendar, maybe a few months down, a few weeks down, depending on the project, to go back and say, have the assumptions changed and how we made the decision? If yes, we will revisit it. Otherwise, just keep going. That's something that is unique to probably leading R&D teams versus I've led, commercial and other teams as a TA head. They don't really have that need to have a debate and alignment. That's a bit of difference between your question about the R&D side of the organization and the commercial or other functions I see, where there is an intellectual need to debate properly and then to come to a decision.
And specifically then when evaluating risk, what would you say were the biggest risks with the NLRP3's inhibitors? Scientifically or regulatorily?
Yeah, so I think when you do any drug development, you're actually looking at technical risk, regulatory risk, and then ultimately commercial risk. So when I mentioned to you the paths to patients that we've chosen, cardiovascular, for example, is, in my view, almost completely de-risked because the step right after NLRP3 called IL-1 has already shown hard outcomes in cardiovascular disease. There are 5 cardiovascular outcomes ongoing about the other side of the downstream pathway called IL-6. So when things downstream actually have shown to be effective biologically, that almost takes away the technical risk of will this drug actually work. Then you've got execution risk. So you actually have to have great teams, motivated, committed, disciplined to execute. I mean, I'm proud to say we have that. And that's part of a CMO's role, to keep them motivated, engaged with the purpose to keep going. Then you've got regulatory things to bear in mind. And that's where it's very important, I believe, to be in conversations with regulators officially, but also at conferences and others, you try and get the feel of what is it that they're actually thinking about at think tanks and places. The final thing actually is commercial and return of capital too.
What commercials in, like, having that in mind, you mean?
Yeah, so I think, often people get enamored by a mechanism and say, I'm actually going to make a drug for something really important. But we've got to realize that we actually are using capital that is fungible, that could come to our company, our industry, or somewhere else. So the way to make our industry successful and self-sustaining is actually to have meaningful returns of capital in a shortened period of time. So when I prioritize indications, the first thing is what's the unmet need for patients. I call it the first P. The second one is what value would I give it to providers. Second P. And the third P is what would it mean for payers? The payers like the NHS or the insurance agencies who actually pay for it, but also who are actually paying for this innovation are venture capitalists, big pharma, P&L thing. How do we return that capital? So if you go systematically, therefore, you can rank order, to your point, in a debate, you can rank order, okay. Like, for example, cardiovascular disease for NLRP3, technically de-risked, the path to approval, and it's actually a totally addressable market that, there are many other drugs in. So that almost takes away the commercial risk to a point where you can actually quantify it and then discharge that risk as you go along the development pipeline.
And I suppose simplifying that and how you communicate that to an investor, for example, is a key part of that story as a CMO.
Absolutely. I think the CMO has to have credibility in the field, should know the science, but not drown the world in the complications of science. And I see the CMO medical role as an ambidextrous role. One day you're actually deep in the science, looking at the mouse data and which neurons are actually lighting up when your drug is on board. And the second day you're actually speaking to the investors in the commercial world on what value you bring to the other side. So that's what actually excites me quite a bit, that actually you can wear two hats. Maybe in two back-to-back meetings, you're in a completely different place. But yet you have the integrity to always be scientifically strong and to be commercially or financially savvy.
That specific thing there, was that a big shift from big pharma to biotech? Because I imagine it would be.
Yes and no for some people, but even at Amgen, I was privileged to lead a cross-functional team which had commercial access, manufacturing, program management, all sorts of things. And at that point, it was actually approaching many, many billions in sort of revenue. So one thing you take away is actually going to be very humble in knowing what you do not know and be very open about learning. So even though I am a physician scientist, I found time spending picking colors for a brand or debating the taglines or very, very useful, because that's how you actually get to patients.
Yeah.
To the point about serving patients. If those things go wrong, your wonderful molecule remains a wonderful molecule, not a meaningful medicine.
Yeah.
And obviously when it comes...
That's a great phrase, by the way.
But when it comes to a smaller biotech, you've got to be even more humbler, in my view, because in large pharma, you have committees and cross-functional teams. They are your checks and balances to actually make sure nobody's blind spot or ego comes in the way of a bad decision, right? Or execution. Whereas in smaller teams, you could be the CMO and people might take your word as the final authority. So that tells me again, before you open your mouth and give you, this is my view, be much more humbler, take other views, and even take external views. I mean, I use the network of experts, thought leaders, but also retired regulators and others. Say if I were to come to you, if you're still at agency X, and I came with this, what would you think? They would be like, Jyothis, I would think you're completely nuts. Or I would think, you have a path forward. And you got to have that humility that you are still learning. Otherwise, I think once you stop growing, the path is only towards death. You're declining, right? So that you have to find a way to keep growing in some domain or the other.
And how do you take that into your leadership style when trying to motivate your teams and things like that?
I think that's exactly what it is. So I think there is a wonderful book. When I joined Amgen, one of the EVPs gave me a book called 6 Simple Rules something. And the rule number one
What's called Sticks?
I think I'll have to come back to you who actually wrote it. I think it's from BCG Founders or something like that. One of the early consulting gurus wrote this book. And rule number one is know what your people do. It sounds very simple, but you actually have to find out what they do how many hours a day and how many hours a week. And when you find that, you realize, maybe some of those things that they are actually doing are absolutely high value and the organization doesn't see it. So as a leader, you can bring that forward. Or you might see they're actually struggling with this particular IT system you put in place and you think you're helping them, but they're actually not being helped.
Slowing them down.
Yeah, slowing them down. So you remove barriers that way. So I think therefore it's just being humble, and of course you would think that they would all look at you as a peer. In reality, they don't. They actually will actually want to, how do you say, look up to you and have answers from you. But what I tell myself is don't give the answer. Try and make them give the answer, which at least for me, it gives me more thinking time before I give the answer. But at least for the other person, it gives some opportunity. Okay, what would I do? I often actually ask leaders or even junior team at large companies, smaller ones I do, what would you do if you were the CEO or CMO? I mean, like then you would take them away of this organizational barriers. Okay, what would you do? Then no, I would do. Okay, then why are you not doing it now? Is a bit of a question or approach to do.
Yeah, I can imagine how putting yourself in the shoes of a CMO when, say, you're a medical director or something is a big step, but actually having the end in sight can give clarity to your decision making.
Yeah, and I was fortunate to actually work with CMOs and heads of development or commercial leaders who rarely actually said, this is what you have to do. They would often ask, okay, we know you haven't done this before, but still, what do you think you should do? And often in the early days, I was completely off the mark, but they were patient enough to say, you got something there, think a little bit more. And I think that's very important that actually you invest forward into that generation. I caught up just last week with my very first CMO who I reported to, and I've seen him grow even from then. And I think he was delighted that, I haven't completely screwed up or actually brought up, right? So that's the sort of thing that you want. People change companies, people will change job titles, but I think that human respect and relationship is something that we carry forward.
And do you retain mentors in that world?
Absolutely.
You do, yeah.
My personal coach is still the very person I had as the very first executive coach, because then you grow with them. And I don't even pay him these days, but he's like, Jyothis, I want to talk to you because I want to help you, right? It's that sort of relationship. Yeah. So it's very important. There are a lot of people who actually come to you and say, can he be your mentor and things like that, just so they can take a box to say, I've got a mentor. But mentorship and support is much more than that. You've got to take your time. And once you pick a mentee too, I'm very selective in picking people, but then I invest in them. Actually, I tell them, hey, have you found this opportunity that you could apply for? And they would say, no, I'm not ready to be VP. No, I think you're ready. There is that sort of reinforcement sometimes to give people to actually go forward.
And do people seek you out for mentorship, or is it like someone in your network who's kind of heard about you in a certain area?
They do, and they do it for different reasons. Some people actually reach out because, you are somebody who's gone from academia to industry. How is that? And these days people reach out, or you've actually gone from big-Pharma to biotech. How is that? Can I talk to you? People reach out for other reasons, like you are from a UK background, went to the US, can I talk to you about that? But I was surprised actually when I went to the US, lots of people of color and minorities reached out to say, Jyothis, you are a leader in a diverse setting. I had not seen myself as a man and in the UK like that, but they were like, oh, I want to talk to you because we need that sort of people who look like me to be my mentor. I'm like, okay, I had not thought about that before, but happy to do that, right?
That's interesting. So you didn't get approached for that in Europe, but you did in America?
Maybe that was a time when DEI was in the vogue, or maybe that was just there was a subgroup that actually was looking at South Asians or something. But I did actually stop for a moment to think, I hadn't had that question in the UK, but I had this now.
Yeah.
So, you're right.
It's a powerful message, isn't it?
It is a powerful message, and actually that also means that what people are looking for in this broad term for mentorship are often many things. And again, often when I'm very selective, but when I actually meet with somebody, I often listen for the first half an hour. And I actually sometimes these days say, I am just not the right person for you. I know not enough about AI and your field of work to know what it is. Then they often say, no, I don't want your advice about AI. I know everything about AI and model building. What I want is that other bit of how did you make that cultural transition from this ethnicity to the UK context to the US. Okay. And then I'm like, okay, that I can help with you.
Yeah.
And it's a very focused discussion thereafter.
And so So what then does diversity mean to you? As in like effective diversity to you?
I think effective diversity goes back to me, that sort of debate, decision, and delivery. When you actually have a monoculture, whatever else it is, you actually have a groupthink very quickly. So that diversity of thought is very important. Diversity of thought can actually come from your background, your training, your geography. I don't really mind where it comes from, but you really need to have diversity of thought. And as the leader, one has to seek out alternative ideas. That's what I love the Amgen culture. At every meeting, we actually would say, does any of you have a disconfirming view? Even as the leader, you actually seek out an alternate view that disconfirms your view. So that's very important. So diversity for me is much more than a label. It's about how you make effective decisions. And on the delivery too, on the execution, if you again have a monoculture, you actually have blind spots of how you actually execute it. But in teams where actually people have come from different backgrounds and different contexts, they are often able to see, I can actually see this thing going wrong there, or I can see an opportunity where you can actually cut time because I have done something like that in other contexts. So you bring that diversity to that thought. I don't like the political discussion at all, but I stay to what is that leadership applicability, right?
Yeah, and that's what I mean by effective. It's like with an end goal in mind, how you bring the team together to get optimal results to, again, benefit the patient and things like that.
Absolutely.
So in terms of the future then of the cardiometabolic and endocrine space, what do you think will be the big developments to keep an eye out for over the next 5 to 10 years, say?
Yeah. So I think, the therapies have transformed. The plays include GLP-1s and SGLT2s that you mentioned. The next stage of innovation would need to come from things that actually address both the causes of cardiometabolic disease and the consequences of the disease. And the new innovations need to be almost like a perfect partner for SGLT2s, GLPs, which will be generic in the very near future or already, right? So you have the foundation laid, and the next layer would actually come from oral scalable solutions. And that's why I'm so excited about the NLRP3 and the chronic inflammation space. Inflammation is being recognized as a risk factor for cardiovascular disease. I was at the European Congress recently, and American College of Cardiology has just published a statement on inflammation and cardiovascular disease, putting inflammation really as a single independent risk factor. And you also have that medical thinking being blended by a lot of wellness people talking about inflammation as a reason for preventing aging and a lot of things.
In a good way or a bad way?
In a bad way, that actually chronic inflammation actually leads to accelerated aging. So I was excited when I joined NodThera that mice, for example, where this particular chronic inflammatory pathway is knocked out, those mice live 30% longer. Now, we don't have a regulatory path for that, for this drug, but I think that's where you would see innovations in chronic inflammation dampening coming in through. And clearly, I am absolutely biased, but I do see that brain-penetrant NLRP3s would be a next mega class in cardiometabolic disease because they do all the three things I mentioned: metabolic benefits, improvements in how you manage, control your weight, and most importantly, the consequences of cardiovascular disease and neurodegeneration and other things.
And do you think there are any overlooked or underinvested opportunities in that space?
There are often herd mentality that everybody actually wants to go into the most attractive thing. I mean, that's not just in our industry, it's across the field.
Absolutely,
Capital follows the thing.
I've seen that.
But I think the smart folk are increasingly recognizing that you actually need to find what scientists call orthogonal mechanisms, or what I call leapfrogging opportunities, where actually you back new next mega classes in a big way. And you've seen successes of that in the recent past, right? The acquisitions on the NASH front by the big companies, on what Mentorship has done for obesity, or Tourmaline has done in cardiovascular disease. So I think the next thing would be based on good science, good clinical acceleration, and finally addressing the unmet need from the causes of cardiometabolic disease and the consequences, I feel.
You talked earlier about the herd mentality. I relate that to London bus syndrome. So I see that a lot with biotechs at the moment when it comes to investment. So you'll see certain spaces that weren't investable, in inverted commas. Now you've got, a flurry of different investors, queuing behind each other to get involved. And it's interesting where that will take, because I remember when I first started with Arta, for example, where you could see that diabetes and the kind of more mainstay part of endocrinology weren't seen as, you know, a new early stage R&D area of interest, whereas in the past 2 years I've seen that radically change, you know, and I'm fascinated to see where that R&D is going to take us. So I'm going to keep an eye out for what you're saying right now.
Yeah, please do. But I think what you say is also right, that there is actually often mega trends that come about one particular disease area that is hotter or less hot than the others. But if you just think about the unmet need in the world, what is the number one killer in the world? Cardiovascular disease. What is the root cause of most of modern chronic illnesses? Obesity. And if as a society, if as an investment community, if as biotech leaders, we think that's going to go away, you're burying your you're burying your head in the sand, right? So you go to actually see where the real unmet need is, and then find smart, effective ways to unlock that unmet need, not just go with the 450th GLP-1 that is following on.
Yeah, I think there was 140 obesity assets under development in the US right now, not including China.
I don't know the exact number because that number is exploding every day. But yet, if you look again, you actually see what I told you was the incumbent class. Then you got the fragmentation of the incumbent class and the innovators. So I'm still thinking that when you have 1 billion people out there, there is so much more room for new mechanisms to come in and carve a meaningful opportunity. And the final thing actually is combination therapies. If you look at hypertension, you mentioned diabetes. These are all good examples where over the long term, these are chronic progressive diseases and patients would need more than one mechanism.
Mm-hmm.
So just to think that, a GLP-1 or an SGLT2 will solve the problems forever is again a very simplistic thinking that, you can fall into that sort of simplistic mindset, but the job of people like me who spend our lives in cardiometabolic disease just remind people, hey, these are the unmet needs, and then at the same time, that's the investment opportunity to go after.
And now that you've moved into biotech, I suppose when you were on the pharma side, you were able to explore what made a good asset from a commercial perspective, but also what, say it's business development activities and you're looking to acquire molecules, assets or companies. Now that you're on the biotech side, what do you think differentiates leaders that can scale biotech effectively and progress to ones that, won't necessarily?
Yeah, I think a lot of biotech leaders, especially the smaller ones, they start with developing a mechanism or a molecule. And that's the remit, and that's what they should do, and that's where the innovation comes from. Yet, as the mechanism matures or the company matures, you've got to start thinking about the 3 Ps that I mentioned. How will it serve patients? Who are those exact patient types, right? And that leads to the right indication being selected. The second thing is, how will it actually help providers? They've got a bunch of medicines they already have to deal with, which is pretty hard. And then how will this differentially add value to the prescriber? The third thing is, how is it actually going to solve the payer's problems, right? If you can address 2 of these at least, it's great. If you can address all 3, it's fantastic. So you actually have a systematic method in actually taking your science and overlaying that with what is it for patients, what is it for providers, what is it for payers. I think if you do that smartly and collegiately, I think you would actually unlock so much value in the biotech place.
What would you like your legacy to be when you leave the industry?
I hope I'll not leave it completely because I hope, at least as a elder statesman in my 70s, 80s, with all the cardio protection I'm trying to practice, I would live on. But
You're a young man, obviously. But yeah.
The one thing, Lawrence, actually is legacy number 1 would be the people you train and support. Mm-hmm. I benefited from academic and industry leaders who invested enormously. Number 2 would be, I want to count my success and my team's success in how many millions of patients we served. I mean, that's even at Amgen, my commercial colleague and I, we came up with that as the success metric we would measure by. And you know what? It energized the team. It actually transformed the business too.
Yeah, I bet.
Yeah, you actually get that thing too.
It's very inspiring.
Yeah, the people you leave behind as your next generation of success and the people you serve with your medicines, those are the 2 things I would think as the legacy. Do
you know what the cumulative number of patients that you've treated successfully is?
Empicliflozin I worked for is a multi-billion asset. Then at Novo, I was leader of a full portfolio across Europe. Then with Amgen, I had PCSK9 and then the full general medicine thing.
Yeah.
So it is in the millions, which is pretty good.
It is, yeah.
Not bad, I would say.
I'd say it's very good.
Yeah.
Yeah, it's a good one to keep tabs off for the CV that people haven't ever done before.
Yes, but I tell people actually that how lucky is it that actually you can tell that you have actually touched the life of millions of people out there. Somebody is popping a tablet in the morning, hoping to have a better day and a better life because you invested some of your prime time and lack of sleep in actually building that molecule or the product forward.
Have you ever had a letter from a patient?
I actually have had real patients who actually come and actually hug me for the work that somebody else had done, because this is a team sport.
Yes.
And they say, I'm so lucky that, you discovered this molecule. I'm like, I had no idea how this molecule was discovered, but I will take your hug. Thank you very much. And I'll pass it on. Yeah. So we actually went brought some of those patients onto campus. And then literally everybody around me was crying, and I'm not a crying person usually, but I was crying too when they actually say thank you. And if as a company, if you're not doing it of bringing patients into your company, please do. I mean, one thing that's common between BI, Novo and Amgen where I worked with was actually getting that patient's perspective into the company. And I would encourage, even as a small biotech, go find your local NHS clinic or US clinic and go see some patients. It will actually energize your people. It will refresh your purpose. And you know what? It might actually lead you to some good insights of how to develop your medicines better.
Yeah, and I think it does link back to purpose, as you just mentioned from the beginning of the podcast. So final question, Jyothis. How, for the audience out there and the listeners, what's the best format for them to contact you?
I'm not a huge social media person, but I do have a very active LinkedIn account, and I would encourage people to reach out through LinkedIn, and that probably is the best way. And of course, NodThera has our website, nodthera.com, or our LinkedIn profile. But personally, LinkedIn, company, nodthera.com.
Thank you, Jyothis. It's been a pleasure.
Thank you.